Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of Hurler Syndrome, also known as Mucopolysaccharidosis Type 1, designed for general pediatricians. This is a lysosomal storage disorder caused by a missing enzyme, which leads to progressive damage in the bones, brain, heart, eyes, and airways. We will work through 16 carefully crafted clinical cases, covering clinical presentation and recognition, the neurological progression, examination findings, the underlying pathophysiology, the genetic basis, diagnostic investigations, the subtype spectrum, treatment with enzyme replacement and stem cell transplant, surgical needs, complications, and long-term prognosis. Let us begin. Question 1. An 18-month-old boy presents with developmental regression since 8 to 10 months of age. His history includes 2 hernia repairs, noisy breathing, and what the parents call a big tongue. Head circumference is at the 98th percentile, and examination shows a flat nasal bridge and periorbital puffiness. Which combination of features is most characteristic of Hurler syndrome in this age group? Option A, progressive coarsening of facial features, macroglossia, flat nasal bridge, macrocephaly, recurrent hernias, and recurrent upper respiratory infections. Option B, hypotonia with absent deep tendon reflexes, a cherry red spot on fundoscopy, and hepatosplenomegaly. Option C, episodic hypoglycemia, elevated lactate, hepatomegaly, and lactic acidosis. Option D, alopecia totalis, photosensitivity, angular stomatitis, and recurrent skin infections. The correct answer is option A. The hallmark of Hurler syndrome is the progressive coarsening of facial features, with a flat nasal bridge, thick lips, macroglossia, and gingival hyperplasia, all appearing in the first 1 to 2 years of life. Macrocephaly, with head circumference crossing upward across percentile lines, is an early red flag. Recurrent hernias, both umbilical and inguinal, are often the very first surgical presentation of this disease. Recurrent ear infections and noisy breathing reflect glycosaminoglycan deposition in the mucosal tissues. Options B, C, and D point instead to Tay-Sachs disease, an organic acidemia, and a nutritional deficiency, none of which is mucopolysaccharidosis type 1. Question 2. A 2-year-old girl is referred for developmental regression. She had 20 words at 18 months, but now most of her speech is lost. Head circumference is rapidly increasing, above the 99th percentile. Her parents note a prominent mid-back lump and an enlarging abdomen, and her gait has become unsteady over 3 months. Which pattern of neurological involvement is most expected in untreated severe Hurler syndrome? Option A, acute encephalitis-like episodes with cerebrospinal fluid pleocytosis and fever. Option B, peripheral neuropathy with absent reflexes, distal muscle wasting, and sensory loss. Option C, progressive cognitive decline with developmental regression, communicating hydrocephalus, and a risk of cervical myelopathy. Option D, focal seizures, cortical tebers, and periventricular calcifications on brain-computed tomography. The correct answer is option C, progressive cognitive decline with communicating hydrocephalus and a risk of cervical myelopathy. In untreated severe mucopolysaccharidosis type 1, early development is normal, then plateaus, and then regresses, typically between the ages of 2 and 4 years. Communicating hydrocephalus develops because glycosaminoglycan deposition and dural thickening impair the reabsorption of cerebrospinal fluid, producing macrocephaly and enlarged ventricles. Cervical myelopathy arises from odontoid dysplasia and progressive dural thickening, which can compress the cord and cause upper motor neuron signs, even after a stem cell transplant. The distractors point elsewhere. Option A suggests herpes encephalitis, Option B a peripheral neuropathy, and Option D tuberous sclerosis. Question 3. A 14-month-old boy is seen at a routine well-child visit. His head circumference is above the 98th percentile with a prominent forehead. He has periorbital fullness, a flat nasal bridge, and gingival hyperplasia. There is a protuberant abdomen with an umbilical hernia, loud snoring, and 4 respiratory infections in 6 months. He is not yet walking, and slit lamp examination reveals bilateral corneal haze. What is the most likely diagnosis? Option A, achondroplasia, an FGFR3 mutation causing short limb dwarfism. Option B, Sotos syndrome, with cerebral gigantism, macrocephaly, and developmental delay. Option C, G1 gangliosidosis, a beta-galactosidase deficiency with a cherry red spot. Option D, Hurler syndrome, Mucopolysaccharidosis type 1H, an alpha-L dihydrogenase deficiency with glycosaminoglycan accumulation. The correct answer is option D, Hurler syndrome. The classic triad to remember is coarse facies, corneal clouding, and organomegaly. Together, this combination is mucopolysaccharidosis type 1 until proven otherwise. Corneal clouding is an especially important early sign because it distinguishes mucopolysaccharidosis type 1 from type 2, also called Hunter syndrome, which has no corneal involvement. GM1 gangliosidosis can mimic mucopolysaccharidosis type 1, but it shows a cherry red spot on the macula, which is absent here. Achondroplasia causes short limbs without clouding or organomegaly, and Soto syndrome is an overgrowth disorder with no corneal signs. The corneal haze is the key that points to mucopolysaccharidosis type 1. Question 4. A 3-year-old is referred for being a, quote, funny-looking child. Examination reveals macrocephaly, bilateral corneal clouding, coarse facial features, thick lips, gingival hyperplasia, limited neck extension, hepatomegaly, splenomegaly, a thoracolumbar kyphosis described as a gibbous deformity, and a claw hand deformity with an inability to fully extend the fingers. Which combination of examination findings is most pathognomonic for mucopolysaccharidosis type 1? Option A, corneal clouding, dysostosis multiplex with gibbous, claw hands and joint stiffness, and hepatosplenomegaly. Option B, a macular cherry red spot, hyperreflexia, and hepatosplenomegaly. Option C, angiokeratoma on the trunk, peripheral neuropathy, and renal disease. Option D, hypopigmented ash leaf macules, seizures, and cardiac rhabdomyoma. The correct answer is option A, corneal clouding, dysostosis multiplex, and hepatosplenomegaly. This combination is the pathognomonic triad, highly specific for mucopolysaccharidosis type 1, whether Hurler or the intermediate Hurler-Shy form. Dysostosis multiplex is the characteristic skeletal pattern, a gibbous deformity from thoracolumbar kyphosis, claw hand contractures, joint stiffness, a J-shaped sella, and oar-shaped ribs. Corneal clouding, once again, is what distinguishes mucopolysaccharidosis type 1 from type 2, since Hunter syndrome has no corneal clouding. The other options point elsewhere. Option B suggests Tay-Sachs, option C suggests Fabry disease, and option D suggests tuberous sclerosis. Remember, mucopolysaccharidosis type 1 with corneal clouding dramatically narrows the diagnosis. Question 5. A pediatric resident asks during rounds, I understand there is an enzyme missing in Hurler syndrome, but why does this cause problems in the bones, brain, heart, eyes, and airways all at once? You are about to explain the fundamental pathophysiology, which best describes the underlying cellular mechanism causing multi-organ dysfunction in mucopolysaccharidosis type 1. Option A, mitochondrial electron transport chain dysfunction leading to energy failure in high-demand organs. Option B, hexosaminidase A deficiency leading to ganglioside accumulation specifically in neurons only. Option C, abnormal copper transport leading to toxic copper accumulation in the liver and brain. Option D, deficiency of lysosomal alpha-L iduronidase leading to a failure to degrade dermatan sulfate and heparan sulfate with glycosaminoglycan accumulation in virtually all cell types and progressive multi-organ dysfunction. The correct answer is option D, alpha-L iduronidase deficiency. The alpha-L iduronidase enzyme normally cleaves iduronate residues from two glycosaminoglycans, dermatan sulfate and heparan sulfate. Without this enzyme, lysosomes fill with undegraded glycosaminoglycans, and the cells become, in effect, stuffed. Because lysosomes exist in virtually every cell type, this explains the universal organ involvement. Affected cells include neurons, chondrocytes, corneal keratocytes, cardiac fibroblasts, hepatocytes, and airway epithelium. The result is organomegaly, skeletal dysplasia, corneal clouding, neurodegeneration, and valve disease. The other three options, mitochondrial dysfunction, hexosaminidase A deficiency, and abnormal copper transport, do not apply to this disorder. Question 6. The parents of a newly diagnosed 18-month-old with Hurler syndrome ask about genetics. They have a healthy 5-year-old daughter and a 10-week pregnancy, and they want to understand the inheritance pattern and the genetic basis of their child's condition. Which statement correctly identifies the inheritance pattern, the causative gene, and the substrates that accumulate in mucopolysaccharidosis type 1? Option A, autosomal recessive, the IDUA gene on chromosome 4p16.33, accumulation of dermatan sulfate and heparan sulfate. Option B, X-linked recessive, the IDS gene on chromosome XQ28, accumulation of dermatan sulfate and heparan sulfate. Option C, autosomal dominant, the IDUA gene on chromosome 4p16.34, accumulation of keratan sulfate. Option D, autosomal recessive, the GALNS gene on chromosome 16q24.33, accumulation of keratan sulfate and chondroitin 6 sulfate. The correct answer is option A. Mucopolysaccharidosis type 1 is inherited in an autosomal recessive pattern. The causative gene is the IDUA gene, located on chromosome 4p16.3, and over 200 pathogenic variants have been identified, the most severe being PW402X and PQ70X. Because the inheritance is recessive, each parent is an obligate carrier, and there is a 25% recurrence risk with each pregnancy. The substrates that accumulate are dermatan sulfate, found in connective tissue, skin, and heart valves, and heparan sulfate, found in the central nervous system, basement membranes, and organs. It is worth noting that mucopolysaccharidosis type 2, Hurler syndrome, accumulates the same two substrates, but it is X-linked rather than autosomal recessive. Question 7. A 20-month-old boy presents with coarse facial features, hepatomegaly, and developmental delay. Mucopolysaccharidosis is suspected. No newborn screening was performed, and you need a cost-effective, non-invasive first step to begin the diagnostic workup. What is the most appropriate first-line screening test for suspected mucopolysaccharidosis type 1 in this child? Option A, skeletal survey, a full-body X-ray series to identify dysostosis multiplex. Option B, brain magnetic resonance imaging with and without contrast to evaluate white matter changes and hydrocephalus. Option C, quantitative urine glycosaminoglycan analysis with electrophoresis, showing elevated dermatan sulfate and heparan sulfate. Option D, bone marrow biopsy to identify foam cells and storage macrophages. The correct answer is option C, quantitative urine glycosaminoglycan analysis with electrophoresis. This is the appropriate first-line screening test because it is non-invasive, cost-effective, and widely available. In mucopolysaccharidosis type 1, the pattern shows both dermatan sulfate and heparan sulfate elevated. Its sensitivity is high in severe Hurler disease, but it may miss the milder attenuated forms, so false negatives are possible. For that reason, if clinical suspicion remains, you must always follow with an enzyme assay. The diagnostic sequence is urine glycosaminoglycan screen first, then the alpha-L-iduronidase enzyme assay, then gene sequencing. Never stop at the urine glycosaminoglycan result alone. Question 8. A 20-month-old boy has a urine glycosaminoglycan analysis showing significantly elevated dermatan sulfate and heparan sulfate. You now need to confirm the diagnosis of mucopolysaccharidosis type 1 and distinguish it from other mucopolysaccharidosis types. What is the gold standard confirmatory diagnostic test for mucopolysaccharidosis type 1? Option A, skin biopsy with electron microscopy to demonstrate lysosomal inclusions. Option B, brain magnetic resonance imaging showing periventricular white matter signal abnormalities. Option C, full-body computed tomography scan demonstrating hepatosplenomegaly and skeletal deformities. Option B, alpha-L-iduronidase enzyme activity assay in leukocytes or a dry blood spot confirmed by IDUA gene sequencing. The correct answer is option D, the alpha-L-iduronidase enzyme activity assay confirmed by gene sequencing. This is the gold standard confirmatory test for mucopolysaccharidosis type 1. Enzyme activity is measured in leukocytes, plasma, or a dry blood spot. In Hurler disease, that is type 1H, the activity is undetectable or severely reduced, less than 1% of normal. In the intermediate Hurler shy form, residual activity is 1 to 5%, and in the mildest shy form, it can be up to 10% of normal. Gene sequencing of the IDUA gene then confirms the diagnosis, helps predict severity, and enables family counseling. Skin biopsy is nonspecific, brain imaging is supportive but not diagnostic, and computed tomography shows only structure, with no enzyme data. Question 9. A 16-month-old girl with newly confirmed mucopolysaccharidosis type 1 HH high with undetectable alpha-L-iduronidase activity and a homozygous W402X mutation is being prepared for treatment. Before starting enzyme replacement therapy and stem cell transplant evaluation, a baseline multi-system assessment is required. Which baseline investigation is most critical to assess cardiac involvement before treatment? Option A, echocardiogram to assess for valvular disease and cardiomyopathy. Option B, a 24-hour ambulatory electrocardiogram, a Holter monitor, to detect arrhythmias as the primary screen. Option C, serum troponin I and B-type natriuretic peptide levels as the sole cardiac assessment. Option D, chest X-ray and 12-lead electrocardiogram only without further cardiac imaging. The correct answer is option A, an echocardiogram. Valvular disease occurs in virtually all patients with mucopolysaccharidosis type 1. Mitral regurgitation is the most common lesion, followed by aortic regurgitation. Glycosaminoglycan deposition thickens both the valve leaflets and the myocardium, and concentric left ventricular hypertrophy is frequent. A baseline echocardiogram is mandatory before a stem cell transplant because of the surgical risk and before starting enzyme replacement therapy. In terms of prevalence, valvular disease affects more than 90% of patients, and left ventricular hypertrophy or cardiomyopathy roughly 60%. The complete baseline in a newly diagnosed patient also includes brain and spine magnetic resonance imaging, slit lamp examination, audiometry, a skeletal survey, a sleep study, pulmonary function testing, and a developmental assessment. Question 10. A 7-year-old boy is referred for short stature and joint stiffness. He attends mainstream school with mild learning support. He has bilateral corneal clouding noted incidentally, mild facial coarsening, and joint contractures limiting hand extension. There is no hepatosplenomegaly. Urine glycosaminoglycan shows elevated dermatan sulfate and heparan sulfate, and the alpha-L iduronidase enzyme activity is 3% of normal. Which mucopolysaccharidosis type 1 subtype does this presentation best represent? Option A, Mucopolysaccharidosis type 1H, Hurler Syndrome, the most severe phenotype with rapid neurological decline in infancy. Option B, Mucopolysaccharidosis type 1HS, Hurler Shy, an intermediate phenotype with variable cognitive involvement and later onset. Option C, Mucopolysaccharidosis type 2, Hunter syndrome, which is X-linked with corneal clouding absent. Option D, Mucopolysaccharidosis type 3A, Sanfilippo, with severe neurodegeneration, mild somatic features, and no corneal clouding. The correct answer is option B, Mucopolysaccharidosis type 1HS, the Hurler Shy intermediate phenotype. Residual enzyme activity defines the severity across the spectrum. Hurler has less than 1%, Hurler Shy 1 to 5%, and Shy 5 to 10%. This child, at 3%, falls squarely in the intermediate range. The clinical picture fits as well: a mainstream school placement, only mild cognitive involvement, and joint stiffness, rather than the severe infantile decline of classic Hurler. The presence of corneal clouding rules out Hunter syndrome, since type 2 is X-linked and has no corneal clouding. That single sign confirms the mucopolysaccharidosis type 1 spectrum. Sanfilippo is ruled out because it causes severe central nervous system disease with no corneal clouding and no significant somatic disease. Residual enzyme activity is the biochemical anchor of subtype classification. Question 11. A 3-year-old boy presents with severe hyperactivity, aggressive outbursts, and sleep disturbances. He has lost most of his language over the past 6 months. Physical examination reveals very mild facial coarsening, no corneal clouding, minimal hepatomegaly, and normal-appearing joints. Urine glycosaminoglycan electrophoresis shows an isolated elevation of heparan sulfate only. Dermatan sulfate is normal. The alpha-L iduronidase enzyme activity is within normal limits. What is the most likely diagnosis given this presentation? Option A, Mucopolysaccharidosis type 1H, Hurler syndrome, with dermatan and heparan sulfate elevation and corneal clouding present. Option B, Mucopolysaccharidosis type 4A, Morchio A, primarily skeletal, with elevated keratan sulfate and no central nervous system involvement. Option C, Mucopolysaccharidosis type 3, Sanfilippo syndrome, with severe central nervous system deterioration, mild somatic disease, and isolated heparan sulfate elevation. Option D, Mucopolysaccharidosis type 6, Maroto-Lamy, with no central nervous system involvement and elevated dermatan sulfate only. The correct answer is option C, Mucopolysaccharidosis type 3, Sanfilippo syndrome. The key features are severe central nervous system deterioration, with behavioral regression and language loss, combined with only mild somatic disease, isolated heparan sulfate elevation, and crucially, normal alpha-L iduronidase activity. Think of the urine glycosaminoglycan pattern as a diagnostic branch point. If both dermatan and heparan sulfate are elevated, you are looking at type 1 or type 2, and you check the enzyme. If heparan sulfate alone is elevated, that points to Sanfilippo syndrome, and the alpha-L iduronidase will be normal. If keratan or dermatan sulfate alone is elevated, you consider type 4 or type 6. The key differentiator here, Sanfilippo has heparan sulfate only with normal alpha-L iduronidase, whereas mucopolysaccharidosis type 1 has both substrates elevated with severely reduced enzyme, plus corneal clouding and organomegaly. Question 12. A 14-month-old girl is newly diagnosed with mucopolysaccharidosis type 1H. Her alpha-L iduronidase enzyme activity is undetectable, less than 0.1% of normal. She is developmentally appropriate, walking, with 8 to 10 words, and interactive. Brain magnetic resonance imaging shows early white matter signal changes, but no hydrocephalus. What is the recommended standard of care treatment strategy for severe mucopolysaccharidosis type 1, Hurler Syndrome, diagnosed before age 2? Option A, start luronidase enzyme replacement therapy as monotherapy indefinitely. Stem cell transplant is only for adults. Option B, substrate reduction therapy with miglustat as the primary treatment, with no need for invasive procedures. Option C, hematopoietic stem cell transplant only. Enzyme replacement therapy has no role in Hurler syndrome. Option D, start luronidase enzyme replacement therapy immediately as a bridge therapy and proceed urgently to hematopoietic stem cell transplant before age 2 to 2.5 years. The correct answer is option D. Enzyme replacement therapy with luronidase is started immediately because it reduces the systemic glycosaminoglycan burden, improves somatic disease, and optimizes the child for transplant. It serves as a bridge therapy. Hematopoietic stem cell transplant then provides sustained, internally produced alpha-L iduronidase through donor-derived microglia, and it is the only therapy that crosses the blood-brain barrier. Timing is critical. Transplant before age 2 to 2.5 years gives significantly better cognitive outcomes. Enzyme replacement therapy alone cannot prevent cognitive decline, precisely because it does not cross the blood-brain barrier. So the two work together, enzyme replacement as the bridge and transplant as the definitive therapy. Question 13. A family whose child with Hurler syndrome underwent a stem cell transplant at 18 months asks why the transplant was done when an enzyme replacement was already available. Their 4-year-old post-transplant daughter now attends preschool with near-normal cognitive function. Which best explains the central nervous system advantage of stem cell transplant over enzyme replacement therapy alone in Hurler syndrome? Option A. Donor-derived hematopoietic cells engraft in the central nervous system as microglia, providing continuous internally produced alpha-L iduronidase. Luronidase enzyme replacement therapy cannot cross the blood-brain barrier. Option B. Enzyme replacement therapy requires monthly infusions, making long-term administration impractical for young children. Option C. Stem cell transplant permanently corrects all bone and joint abnormalities, including the gibbous deformity. Option D. Luronidase enzyme replacement therapy causes severe neurological side effects in children under 3 years of age. The correct answer is option A. Luronidase enzyme replacement therapy is a large protein that is blocked entirely by the blood-brain barrier, so an intravenous infusion gives essentially zero neurological benefit. The transplant works differently. Donor monocytes circulate, cross the blood-brain barrier, engraft in brain tissue, and differentiate into microglia, which then secrete alpha-L iduronidase continuously within the central nervous system. The result is ongoing enzymatic glycosaminoglycan clearance inside neurons and brain tissue, which is sustained, internally produced, and permanent. Children transplanted before age 2.5 years show near normal preservation of intelligence in long-term follow-up. But remember the limitations. Transplant does not reverse established skeletal changes, it does not cure corneal clouding, and it carries significant procedural risk. Enzyme replacement alone gives somatic benefit only. Transplant is the only path to cognitive preservation. Question 14. A 3-year-old boy with mucopolysaccharidosis type 1 is on weekly luronidase enzyme replacement therapy. He has loud snoring, documented obstructive sleep apnea with an apnea-hypopnea index of 22 on a sleep study, bilateral conductive hearing loss, carpal tunnel syndrome with nocturnal hand tingling, and an unreduced inguinal hernia. He is referred for surgical planning. Which combination of surgical interventions is most commonly required in children with mucopolysaccharidosis type 1 managed with enzyme replacement therapy? Option A. liver transplantation to reduce hepatic glycosaminoglycan burden and enzyme deficiency. Option B, tonsillectomy and adenoidectomy for obstructive sleep apnea, ventriculoperitoneal shunt for hydrocephalus, carpal tunnel release, and hernia repair. Option C, bilateral knee replacement for joint destruction and loss of ambulation. Option D, pancreatic enzyme supplementation for gastrointestinal malabsorption. The correct answer is option B, tonsillectomy and adenoidectomy, ventriculoperitoneal shunt, carpal tunnel release, and hernia repair. Glycosaminoglycan deposits in the airway mucosa cause adenotonsillar hypertrophy, leading to obstructive sleep apnea in the majority of patients with Mucopolysaccharidosis Type 1. Communicating hydrocephalus from impaired cerebrospinal fluid reabsorption may require ventriculoperitoneal shunt placement. Carpal tunnel syndrome results from median nerve compression by glycosaminoglycan deposits, and surgical release relieves the symptoms. Umbilical and inguinal hernias are common early surgical presentations. One critical warning: all patients with mucopolysaccharidosis are high risk for anesthesia, with difficult intubation and atlantoaxial instability, so a specialist center is mandatory for any surgical procedure. Before we close, I want to tell you about our community, Pediatric Case Review on Patreon. By joining, you help us create more high-quality, case-based pediatric education. The community offers an organized library with all lectures sorted by body system for easy study and downloadable slides, with every presentation available as images for offline review and practice. There are regular uploads of new cases covering key pediatric conditions, all built around real clinical scenarios designed for practicing pediatricians. If you would like details and to learn how to join, please leave a comment below this video, and we will message you directly. Let us bring this together with the key clinical takeaways for Hurler syndrome. First, recognize it early. Coarse facies, corneal clouding, hepatosplenomegaly, and recurrent hernias in infancy mean Mucopolysaccharidosis Type 1 until proven otherwise. Second, diagnose correctly. Move from the urine glycosaminoglycan screen to the alpha-L iduronidase enzyme assay to gene sequencing, and never skip the enzyme assay. Third, act urgently. A stem cell transplant before age 2.5 years dramatically improves the neurological outcome, so do not delay the referral. Fourth, know the limits. Enzyme replacement therapy does not cross the blood-brain barrier, and stem cell transplant is the only therapy that preserves cognitive function. Fifth, monitor for life. Transplant is not a cure, and cardiac, spinal, airway, and corneal disease all require lifelong multidisciplinary follow-up. And sixth, differentiate the mucopolysaccharidosis types. Type 1 has dermatan and heparan sulfate elevated. Type 2 has the same substrates but is X-linked with no corneal clouding. And Type 3 has heparan sulfate only with severe central nervous system disease. Thank you for joining this comprehensive case-based review of Hurler syndrome. These lectures are made possible by the Pediatric Case Review community. Please remember that this material is for educational purposes only and does not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. If you found this lecture helpful, please follow the channel for more case-based pediatric presentations and leave any questions or topic requests in the comments below. Until next time, keep learning and keep caring for your patients.